Okay, you're a physical therapist.
Correct.
And what is a CCS and an FCCM?
I am a cardiovascular and pulmonary specialist by the American Physical Therapy Association, and I'm also a fellow of the Society of Critical Care Medicine.
Oh, okay, the SCCM.
Correct.
Okay, okay, very good. And you're currently working at Perme ICU Rehab. Is this a private company?
Yes, this is my own business.
Okay, here you go.
Yes, I teach classes for physical therapists how to mobilize patients in ICU. And I also work at Houston Methodist, where I am a clinical development specialist.
Very good.
Okay, so basically, first of all, thank you so much for including me in this program. I'm very excited to have an opportunity to be here and share my clinical experience with all of you. And I'm going to start by saying that the reason I'm here is because I have been doing this for a long, long time. So basically, just for you to have a little bit of idea, I started walking patients on mechanical ventilation in the 1990s, like Dr. Samir just said that at the time that was crazy. I have to be transparent here and say that I had absolutely no clue what I was doing there, and I did not want to be doing that because the only thing that I thought about is just that I was going to kill that patient, just because at that time there was not really any kind of support for that. So basically, a couple of physicians that had a vision that if I only what they would tell me, if I only did my job and got those patients up and walking around, that they would not die and they would do better. So I started doing that little by little, and look at the kind of ventilator that I used at the time. I mean, that was like an SIMV with 100%, very hard to ventilate patients. And then I even walked patients when they were on the T-collar, on the T-tube. I don't even think they do that anymore, but there were some patients that if they could be on pressure support of 5 or some, that we could just take them off the ventilator, walk a little bit and go back. And I continued to do that because when I started to see the results, I realized that as a physical therapist, I didn't really want to do anything else because it was really fascinating. And I continued to do that until it got to the point that I was able to successfully ventilate, walk somebody who is mechanical ventilated also on the ECMO. So basically, before I talk about the patients on ECMO specifically, I'm just going to give a brief overview about the early mobility in the ICU because, again, this is a very hot topic right now. So this is nothing new. We do have some reports in literature in the 1970s in the Physical Therapy Journal and also on the Chest Journal about mobilizing patients that are mechanically ventilated. And in these two reports, they are really talking about the amazing benefits of they had by such practice. Interestingly enough, I have spent a tremendous amount of my life looking at literature because this just fascinates me. I was not able to see a picture of a patient walking on a ventilator or even mention. There were a couple of textbooks, but not necessarily published in medical journals until 2006 when I published that article about mobilizing patients with LVADs that were ventilator dependent, and nobody knew what to do with those patients. So I started mobilizing them, and that's in 2006 was the very first time that I saw a patient that showed a picture of somebody walking on the vent. After that, it was in 2007 that the whole initiative about mobilizing patients started with this publication on critical care medicine by Bailey. So basically what you're looking right there, those 4 articles are the whole initiative that started mobilizing those patients. And that was kind of determined that it was safe, feasible, and improves physical function, also can reduce delirium, and it can also reduce the length of hospital stay and cost. But like I told you, I started doing this in the 90s. None of those articles were published. So the only thing that I had, it was to read about research on bed rest. And I'm going to be honest that the more I read about bed rest and the horrible things that cause to the patients, the more I wanted to get those patients out of bed. And as far as what's going on right now, I don't know that everybody's already familiar with the PADIS guidelines that from the Society of Critical Care Medicine. So what they did, thankfully, they added the immobility to the guidelines, so as well as the sleep disruption. So now I'm sure that not only in this country, but throughout the world, professionals in ICU are going to be a little bit more aware of the risks of, having patients in bed and not really mobilizing them. All right, so now let's go to the topic that I'm here to discuss. So we're going to be talking a little bit about ambulating patients on ECMO. So basically, these are some of the important considerations that I would like to address. So I'm going to go to each one of them kind of briefly, and then hopefully we have some kind of time to discuss the topic. So basically, I'm going to start with the goals. First of all, we have to have a reason why we are doing this, because in my opinion, it's just not because we can do it that we should do it. So we do have to have a reason. So basically, some of the goals when we are able to ambulate these patients is to minimize the harmful effects of the bed rest. Also to promote bronchial hygiene. We all know that the best position for lung function is up and moving. So we have to also think about how that's going to help as far as airway clearance. Minimize the loss of functional mobility, maximize their functional independence, facilitate ventilator weaning, and also promote cost-effective prevention and treatment intervention. So these are the goals for us to take such responsibility of getting those patients up and walking. Are there risks? Absolutely. Like you just mentioned, despite all the benefits, we know that all of this is really going to help the patient, but there are several concerns that we should be aware, and they are related to safety. So we have to determine, if you're going to be doing this, that some patients are very high risk and others are low risk. So there are several factors, and first of all, before we make a decision if they should walk or not, we have to kind of decide if they're high risk. And at the end of the day, it's all about risks and benefits. So we can have the best benefits, but we also have to look at the risks because, like you said, if something goes wrong, there's not a whole lot we can do. So we have to be very careful on the patient selection for this practice. So who are the high-risk patients? I'm going to tell you that the first one is that a patient that does not want to walk. Because even if I have, as a physical therapist, if I have a patient that is not on ECMO, if they don't want to walk, I mean, those are the patients that can hurt you and can also hurt themselves. So the patient has to be willing to put in the effort for that activity. Altered mental status is also very high risk because you never know how those patients are going to react. Patients that have significant hemodynamic instability with position change. If they do not tolerate turning in the bed, I can tell you that they're not going to do well walking up and down the hallway. Not the highway, I'm sorry. The hallway, not the highway. The hallway.
Oh, it's going to be a highway.
It's going to be there, exactly.
It's going to be a highway
Absolutely.
somewhere.
Another very important high-risk patient are the ones who have a significant weakness on the lower extremities. And how do you know that? Very simple. If you ask your patient, can you raise your legs up in the air? If they cannot raise the legs, it's very unlikely that they're going to be able to safely bear weight and walk. And also the patients that it needs 2 staff members to stand. If you need 2 staff members to hold them up, right? I don't think those patients should be walking anywhere. Then you have the low-risk patients. Those are the ones that they want to walk. They are medically stable. So by that, I say that they are hemodynamically stable and they have stable oxygenation and ventilation. In addition to that, they are alert, they follow commands consistently, so they really understand what I'm trying to do. They have at least minimal functional strength. Again, when I just mentioned that, if I ask them to lift their limbs against the gravity, they are able to raise the leg and also keep the knee straight, because if they do not keep the knee straight, they may not be able to bear weight and the knees are going to buckle. And also, the low-risk patients, they are able to stand and walk with minimal assistance of 1 staff member. So this is it. Very important that we kind of look at that and make a decision. The second thing is that it requires an interdisciplinary team for ambulating these patients. I hope you noticed that I did not say a multidisciplinary, because the way I look at it, a multidisciplinary is just you can have all of these professionals, but they're not talking to each other. When you talk about interdisciplinary, that means that they're collaborating, that all of them are, have a part on this. Mm-hmm. So this is the team, and I put the patient at the very top of the list because they must be part of the team, they must participate, they must understand the benefits as well as the risks when we do that. So those are all of the professionals that are going to be involved. And I also include family members and friends. They like to be around because this is an important thing also for them to do.
And it's encouraging. It shows
It is encouraging.
progress.
Yes, absolutely. Now, if we are going to walk away from the bedside, those are the members that must be present in order to ensure safety. So the physical therapist, the perfusionist, and an ECMO specialist, if that's the case, that there's one around, the ICU nurse, and a rehab technician or a patient care assistant. So there's quite a bit of people around because we need to have that team, everybody aware that we are really doing something that it's high risk, and we have to be ready to take that responsibility. And other team members that they have to be readily available is an intensivist and also a physician trained to place the ECMO. Because again, if something happens with oxygenation, I know it's going to be a catastrophic event, but maybe if it's just a little catastrophic, something they can fix it. You know, somebody who knows what to do, you know, could do that. So personally, I have had situations like, for example, on a Sunday where the whole entire team, they were demanding that I really walk this patient, but there was not a surgeon in-house. There was nobody there. So if something goes wrong, I just can't do this. So everything has to be done correctly. In addition to that, for patients that are on mechanical ventilation, the RT must be present to manage a ventilator. And walking activities outside the room is only indicated for the low-risk patients, and I just keep saying that over and over again because that's one of the most important messages that I want to bring here. Now, the safety screen, this is done every single time. That's not going to be done one time. We're going to look at the neurological status. Is the patient able to minimally participate with planned activities? Because again, the patient's status change from day to day, right? It could change even in the same day. The cardiac status, the patient has to be hemodynamically stable. They also have to be with stable ventilation and oxygenation status, and they also have to be able to stand up and take steps. You would not believe how patients' conditions change from one day to another. They may be able to stand today, and the next day they just can't. So that is a safety screen. I'm sure you see that I put some a little, clip art there with a little flag man there. There's not only one, there's 4 of those, because that is one of the most important safety aspects. We have to do that before every single time that we mobilize those patients. Importance of securing the ECMO cannulas properly. We have to make sure that those cannulas are not going to be dislodged. So we take every single effort to secure that in a way that we don't have to worry about it. Now, contraindications. Who are the patients that I talk a little bit about high risk, but if the patients have an unstable ECMO vascular access, this is not going to be an opportunity for these patients to walk because we can't really be doing this. Or if they're having a significant drop in the flow with any kind of mobility activity, or if the cannula does not have a stitch, it's not really secured in place, I think the risk is too much. I don't think it's worth taking that risk. And also, if the patient has active bleeding with a significant drop in the blood count, or if they're recurrently blood transfusions, and we know that the patient is bleeding, and we have to be very careful with that. Also, I would say that pending end-of-life decisions or final decisions for comfort care. And the reason I say that, because when I hear, oh, the patients walk on ECMO, I want everybody to understand that for some of these patients, this is a significant effort. It's just like a fish out of the water. It is very difficult. So they suffer. It's not an easy thing. So we have to really make sure that we are doing the right thing for the right patient. Also, on contraindication, if they have some kind of hemodynamic instability, recurring escalating dose of vasopressors. I've had situations where we've had patients on pressors, and then they wanted the patient to continue to walk, which I really don't feel comfortable doing that, just because, if something goes wrong, it's really going to complicate. And also, another contraindication, if we do not have the sufficient support personnel to ensure patient safety. Okay?
I'm so glad you brought that up. You talked about how much effort it is to do.
It is a tremendous amount of effort.
Because I'm sure you have heard this. I'm sure you have heard this also. John, you may have heard it. I know you've heard it, Patrick, because we all know the same people. And they really think that the ARDS septic patient, flu, influenza derived, that's just really sick. We're controlling their temperature. They're just sick. Is going to get up and walk. They're not going to get up and walk.
Well, sometimes.
Or what do you think?
Well, it's again, this is like the story of my life, because the expectations of the team, they want those patients walking no matter what. And I've had situations when I had to address some, team members. I said, well, think about a day that you had a flu, or maybe you had a severe gastroenteritis that you can barely get out of the couch and you feel so sick. Is that the day that you pack your bag and you go to the gym? I mean, sometimes you just don't feel like doing anything. You don't feel well. And I would say that these patients, for the most time, they don't feel well any day. They still get up and do it, but there are some days that they just can't do it. So we just have to be careful.
I guess I'm saying acute disease versus chronic disease. What's your feelings about that? Do you think there's this mentality to try to push people to do things in an acute disease state where we shouldn't be?
Well, it depends. I mean, different patients react differently. It's hard for you to tell that, but I can tell you, like, for example, if we just mentioned ARDS, those patients, they cannot ventilate, so no matter what you do, they can't breathe.
They have no reserve.
They have no reserve. So it's different, like when you walk somebody with a VA ECMO, they do not really have the respiratory symptoms, they can tolerate a lot better. I mean, I've had patients, they're walking like 2,000 feet and they just walking around.
On VA ECMO.
Yes, and but others, not really. And if they don't have the pulmonary reserve, it's very difficult to tolerate the activity.
Yeah,
and I'm going to show in a little bit a situation like that. All right, so another thing that is very important for us to be aware is, like, what is the criteria for termination of these ambulation activities when the patient is already walking? Anytime the patient has any kind of acute change in the mental status, if they're unable to follow commands and participate, all of a sudden they are not really understanding what you're saying, that kind of already tells you that something is wrong. If we have like a significant drop in the ECMO flows and they cannot correct that, any kind of hypotension associated with fainting, dizziness, or diaphoresis, because we just know that it's going to go worse from that on. And again, significant change in the heart rate or in a change of rhythm. In addition to that, when you have like an SpO2 less than 75 with adequate supplemental oxygenation, so if you've done everything you could and you cannot maintain 75, severe intolerable dyspnea, significant chest pain or discomfort, extreme fatigue, and also if the patient requests to stop. Sometimes they've done enough and they can, please, I can't do it anymore, and I can see that there's always those on the team that they feel like they're the cheerleaders, and no, you can go on, and but there are times that you can clearly see those patients cannot do anymore, so we have to kind of respect that. So here's a couple of patients that, just to illustrate, so this is, you've seen this before, where the patient is intubated and she's also on VV ECMO, and I want you to pay attention on the incredible teamwork that it takes for that, and we have some of the intensivists also available, and it is a lot of effort. Another thing that I want to make sure that for safety, every single one of my patients.
That's my brother.
That's your brother. That's
that
his brother.
That's my brother.
Oh, really?
That was young.
So anyway, so
Not the patient. Not the patient.
is that really your brother?
That's my brother.
Oh my gosh, that's interesting.
Yeah, when I left, he took my place at Methodist.
Oh, really? Oh, okay. So anyways, another thing that I do 100% of the times is that when I walk those patients and they are in the hallway, we always follow them with one of those stretcher chairs. Because again, if any of those patients, if they kind of pass out or something and they're sitting in a regular chair, it's going to take like a incredible effort to safely, return them to the bed, especially if they're not able to stand up and get back to the bed. So I feel like having the stretcher chair where the patient sits in the chair and it becomes a stretcher and we can just do a lateral transfer back to the bed. So 100% of the times, I would not ever, no matter how strong the patient is, how young, how well they're walking, for safety reasons, we always follow them with a stretcher chair. So, okay, so now what happens if the patients are unable to ambulate? Because I'm going to be honest with you, I don't think that really the community realizes that the patients that can ambulate on ECMO, they are really almost the exception. That's not every patient can walk on when they are on ECMO. So basically, if they cannot ambulate, I just want you to know that there are other things we can do. So just general nursing mobility, in bed activities, they just turn side to side or repositioning. They can put the chair, the bed in the chair position, do some exercise in the bed, or they can also be transferred to just a stretcher chair where they don't have to bear weight. Now, as far as physical therapy, there's a lot of things that we can do for those patients. We can educate them about a variety of things, particularly the exercise. That's very important in their progression of activity. Positioning, again, bronchopulmonary hygiene, exercises. We do transverse training, pre-gait activity. Sometimes they're not able to walk, so we spend a lot of time at the edge of the bed, just sit to stand. They're taking steps in place in preparation for the gait re-education, in addition to other things. So here are just a couple of movie clips to illustrate that, like this patient, she was on VV ECMO, femoral, and she was unable to bear weight, and there's no way that she could do that, but she was doing exercises throughout the day, the arms and the legs. This is another one that also could not bear weight, so she's doing exercises with the little weights in there. And all of those, I feel like for those patients, I'm primarily a consultant because in this particular patient, the mother sat at the bedside like probably 20 hours a day, and they did a lot of those exercises. So I was like a consultant. I would change the exercises, but there was a lot of collaboration from other people to do that. This is another, now using exercise equipment. So this is like, for this particular patient, it's almost going to the gym. So we have like equipment that they can do quite aggressive strengthening exercises in the bed. And this is very interesting. This is a patient with a femoral ECMO, VV ECMO, and I put her on this exercise table. And with a lot of help from the perfusionist team and also the physicians, they were able to determine how much she could bend without impacting the flow. And we were doing like, this is the leg press exercise, just like when you go to the gym. Now, when I talked about, like the discomfort, this patient, they finally decided that she had to be pre-medicated with morphine in order to tolerate this. Because she was like, again, just like a fish out of the water, but guess what? She wanted to do it. You know, she was so motivated. She really wanted to participate. And for some patients, if they're unable to bear weight, sometimes we can put them, that's the same exercise equipment, that we can just put them on a tilting position where they can bear weight. I mean, there's no way this person did not have any kind of functional strength to walk, but we could still do some activity to put some weight on the lower extremities. So I want you to know that there's also all of these strategies that we can use for patients that cannot walk, and that is also very helpful. What is the future? Like we just talked about it, I think ECMO is here to stay. Mobilizing patients on ECMO is not only here to stay, but it's just going to continue to be a challenge for all of us. So I got this from the internet. I thought that was very interesting. So not only now we are mobilizing those patients, I mean, you can see this is a patient that he's on ECMO with the Avalon cannula and also on mechanical ventilation. And I'm not so sure what you can talk about this picture, but to me, it's like in the middle of nowhere because, I mean, it seems like he's in the middle of the road, or I don't know.
But it looks like the helipad, and the patient is outside getting sun and feeling
maybe
the outside.
Maybe so, but
that looks like the helipad.
Yes, so we just hope that nothing bad happens there because he's probably long ways from ICU bed. As far as resources available, I have to say that there are so many articles that have been published in the past, I would say in the past 4 years. We have like an incredibly large number of articles published on mobilizing these patients on ECMO. So here I'm just going to talk about one that is a group from the UK. They put a consensus agreement for best practice, and they talked about for adults what kind of physical therapy those patients should have. And also there's one that was published last year on the Annals of Thoracic Surgery about ambulation with femoral cannulation and all of the safety aspects that have to be followed to do that. Because again, now the new thing is to ambulate them on ECMO, and there are several facilities around the country that are mobilizing those patients and walking them routinely with femoral cannulation. So the take-home message, so what is it that I want you to remember is that prevention of muscle weakness during ECMO support is much better than any treatment currently available. And I'm very concerned about sometimes time that is wasted on non-invasive ventilation before the patients are placed on the ventilator, and a lot of time wasted on the ventilator before they make a decision to put them on ECMO. And I don't think that they realize that every single day those patients stay in bed and they're not up and moving, or they are gasping for air, where they're really using all of their reserves. I mean, the likelihood of them ever recovering is their function. It gets very, very slim. So we have to consider that also, and I'm not so sure that is on anybody's mind. I mean, I know that you're trying to save a life, but we also have to start thinking about quality of life. The second one is that physical therapists should be involved with patients on ECMO from the ICU admission. And we are there because we have to do a functional assessment from the beginning to see what are the possibility that patient can start being mobilized. We also can make recommendations, particularly if those patients are not the patients that can be walking, and also to be able to provide patient-centered rehabilitation treatment for those patients. In last slide, ambulation of patients on ECMO support is safe when all of the safety measures are taken. That's the only way. And that was it. So thank you very much for your attention.
Thank you very much. That was excellent. You get a clap on this one. That was very good. You
Thank
put
you.
a lot of information out in a very short period of time. You talked fast. I thought I talked fast. You talk faster than I do.
Well, that way people pay attention.
Exactly. So tell me,
Okay.
if you will, and the phone lines are open, by the way, if anybody wants to call in and ask Christina a question, or Christiane, I keep saying it wrong.
Call me Chris, that's better.
Okay, Chris,
That's
and
easier.
or anybody else, please call in. We do have a question from the web, which I'll ask in just a few minutes, but can you discuss maybe, because it looks like you have, you do seminars and you do some other things. Is there, for anybody that's out there in web world that may have a program that maybe is not thinking about how physical therapy can help their patients, do you have any ways, like this is the best way to reach out to you? Do
Yes,
you
my
provide
email.
that service?
Yes.
Like to outside places? Do you go anywhere? I mean, what do you do? Like, how do you run your business?
What that is that is a 2-day course primarily that I offer that is called Fundamentals of ICU Rehab. And unfortunately, at this point, there's not really a specific training for physical therapists to take care of critically ill patients. So what I do is that I just have this course that I just go throughout the entire country, and then I go to the hospitals and I train their entire staff, or whoever wants to be there. So in 2 days, I teach them about everything about all the lines, all of the mechanical ventilation, and I teach a lot about the weakness that we see for patients in ICU, because this is a completely different kind of weakness. You cannot compare that with any other kind of weakness. And also the therapeutic interventions, how to really mobilize those patients and all the safety issues. So it's like 2 days packed with information to help professionals to kind of go back to their ICU and provide better care for their patients.
John, do you have a robust program where you are, or do you think this would be of some value?
Yeah, that's pretty robust, but I think I saw some things there that I haven't seen them do. I haven't seen leg presses and a few other things in our hospital, so I thought we were pretty aggressive. But there is an aspect of this that that's sort of a thorn in my side, has been for a while. Do you work closely with the nutrition department, and would you ever consider the patients are catabolic and then they're trying to exercise at the same time? Because this is something that I've seen, and I've brought this up ad nauseum in my department, because we see patients lose 10, 20, even 30% of their body weight in a matter of a handful of weeks. And nobody gains weight on ECMO.
Oh, no.
Okay. So, or even probably maintains their same weight. But if they do, it's fluid weight, right? So I asked our cardiac surgeon, I said, are our patients catabolic? He said, they're all catabolic. Well, if you're catabolic, it's basic nutrition to know that you're in muscle breakdown mode. Your body thinks it is starving, and therefore it is utilizing your own muscle tissue for nutrition. So our nutritionists got involved, and I approached them, and they said, well, we give them double the normal nutritional intake for a person this size and whatever. And I said, yeah, but the proof is still in the fact that they're catabolic. On paper, you might be meeting their nutritional needs or then some, but they're still wasting away. And then you take the physical therapist comes in, and they want them to exercise. They're sick, they're very sick, they're catabolic. So you talked about patients who just don't want to do it. And I think an element of that is the fact that your brain tells your body, you are not spending any more calories. You are already wasting away. And I see this, and I just wonder the conflict between what we're doing and the patient's very, very sick, like you said, then the nutritionist who believes they're doing what they're doing, the physical therapist comes in and now they want them to exercise. And meanwhile, the patient's catabolic all the way around.
That is a huge problem. I completely agree with you. But I have to say that, as particular me, I think that what I'm trying to do here is just to keep what they have, you know? And so if patients can tolerate, I go like what the patients tolerate. I routinely check with the nutritionist. And sometimes I've had nutritionists that they're seeing us walk patients in the hallway. And she said, oh my God, I didn't know that this patient was walking. Let me revisit what they're doing to see if I can add something else. I totally agree with you. It's incredibly important. But what is the other option? So sometimes I really don't think, I cannot claim that I make anybody stronger on ECMO, or even if they're not on ECMO, because that's not possible. So what I'm trying to do with these activities is to keep what they have, you know, because sometimes if you can maintain what the patients have, or if you can at least minimize what they lose, that alone is a victory. But I completely agree with you that it concerns me sometimes the fact that they may be utilizing more than they should.
I have two more things real quick. How long do you think a patient, from day one being totally bedridden, do they start to waste away? I guess that's the best way I can put it. I mean, is 3 days of bed rest already impactful, or does it have to be 7 days before they really start to, you know, lose their muscle mass and lose their strength? Do you have any idea about how long that is?
I read a lot about that, so there's a lot of things to consider. Like, for example, let me start first with the kind of patient population that really worries me the most, the elderly. So if you have somebody who is 80 years old and that person comes to the ICU, it could be the healthiest 80 years old on earth, but that patient already has the process that we are familiar with, the sarcopenia. So they're coming to the ICU with 40% less lean muscle mass. So when an elderly person is laying in the ICU, they're literally losing what they don't have. So it's very, very hard for them to ever recover if they lose the little bit that they have. So you have to consider, is that an older patient or a younger person? Another thing that we have to understand is the difference between being on bed rest and being immobilized. Because you can have somebody that is on bed rest, they're just lying down, so that means that they're not against gravity. So they're gonna be deconditioned. But this person that you could be doing exercise, they're clicking the TV button, so you're still, the brain is still connected to the muscles and they can maintain some of that. Now, the minute that you put somebody on sedation, those patients are on a chemical cast. So because you are taking away the patient's ability to think about the muscles and to coordinate the muscles. So if you can imagine, I'm sure you've seen somebody with a cast on the arm. What happens after, you know, like 4 weeks if you take that cast? I mean, there's massive muscle atrophy, there's loss of joints. But the most important thing that concerns me that not many people think about is the coordination, the ability to coordinate the muscles. So a lot of times when those patients, when we say, oh, they're weak, they're also, they don't even know where the muscles are because they haven't been able to think about it. So basically, the data that we have comes from studies that are done in patients that have a cast, okay? Or the bed rest from NASA. We have valuable data from that. So it's hard for me to tell you because there's another thing that we have to consider. If the patients are septic or if they have a systemic inflammatory response, I mean, that is going to really cause a different kind of damage to the muscles, which is different than just somebody who's laying in the bed.
Well,
Does that make sense?
All the ECMO patients are having sears.
Exactly.
They all are,
So
yeah,
then,
100%.
so I'm sorry I can't really answer your question.
No, but it's complicated.
But it's just like there's a lot of things to consider.
I don't know that I would agree with that, what you just said, that all patients on ECMO have sears. I mean, they may have some level of
They have some
inflammatory response
level, yeah.
just from the ECMO, but
Right.
really having sears, I would say that your patients who are, again, you know, the transplant patients who have a chronic illness have adapted to this either pulmonary problem if they have sarcoidosis, or they have some other thing that they're going to be getting a lung transplant, or they have a cardiac problem and they have a VAD in or something like that. They may have had some of that in the initial phase, let's say, of the implantation, but that goes away. I mean, it's somewhat managed. You know, it's not like somebody who is septic, who has that as a major, big problem.
Yes.
But you were talking about sedation. Add sedation and paralytics.
Oh, yes. No, yes.
And
Correct.
everybody
That's what's
you
going
know,
to go next. Yes.
Patients who are going on VV
Neuromuscular
ECMO are getting paralyzed. Who are there because they have severe ARDS, high peak pressures. They can't ventilate them at all, can't oxygenate them at all, and you don't want that person moving it at not even a millimeter, because you have no reserve at all. You have nothing. You're getting nothing from the lungs whatsoever. And I just think they're two different animals. I think
yes.
you really described, but it brings up some very interesting points. But before we get to those 2 points, because I have some points that I want to ask you about too, is I have a message from somebody, Nestor in Texas, said that he wanted to comment on your presentation, that it was definitely an eye-opening presentation. And so you got a compliment there. And also Brian, different issue, he said with the national shortage, this is for Dr. Samir or John, with the national shortage of cardiovascular surgeons, do you see a trend with cardiologists wanting to handle initiating ECMO with perfusion but without a surgeon? I guess also Patrick can weigh in on that. So are you seeing that as well?
Actually, in some institutions, this has been going on right now. These cardiologists want to initiate ECMO, and without surgeons' presence, and to be honest, it's a battle between both disciplines.
What's your opinion? You got one?
I'm biased. I'm much more confident having a cardiac surgeon initiating ECMO in case anything goes wrong. I mean, and I have to tell you, I have to look at the Australian experience. In Australia, I don't know if you know or not, they don't believe in VV ECMO. Anybody in Australia, even ECLS, they get their chest zipped on the floor, chest zipped open, they go on center ECMO.
Oh, really?
Yeah.
They do all central
No
cannulation.
center cannulation.
Wow.
Okay, so I'm very comfortable having a cardiac surgeon available at all times, because when you go to the cath lab, there's a perforation, what they call cardiac surgery. So my full disclosure, all my friends are cardiac surgeons, but your cardiac surgery is the backup for any complication. So you want them available and involved from the beginning.
I agree with that.
Yeah.
I agree with that as well. So, Chris
Yes.
and John, you were talking about, catabolism, and it's the major problem, and so forth. How do you feel, or has there been any work done on this, and am I just absolutely out of my mind to even be thinking this direction? But if you have a 65-year-old, either male or female, who is, maybe the dose would be different, but that is acutely ill, in the bed, going to be like that for a couple of weeks before you're going to be able to do any kind of mobility of them in the bed, maybe not walking, but just to maintain their anabolic state. Has anabolic steroids been useful or even considered, or is that just crazy?
I'm going to be very honest with you. I am not a physician, so I do not, prescribe medications, and I have not seen a whole lot in the literature. Have you seen anything in the literature about that, using the steroids for the
I think they're
patients?
using most testosterone.
Use testosterone, sure.
Testosterone has been a push in patients to help them recover. But testosterone has its own complications, but there has been a big push.
Well, I mean, the complications would be thrombotic. I guess you increase your clotting. So you have a risk of that.
Of
thrombosis.
and stroke, and there was concern about the thrombotic events, cerebral.
Stroke, sure, and then I guess sodium retention and that kind of thing. But is that risk? You think the benefit ratio there in terms of maintaining the patient's muscle mass?
I think, to be honest with you, I've been used successfully. I know one of our nephrologists very strongly believes in it. I mean, that's described as a disease state, low T syndrome. And it's being treated with that. And I'll tell you, one of our nephrologists who's amazingly smart, he uses it on all his patients, and they do very well.
So I'm pretty smart too, since
You've always been very smart.
Okay, I'm pretty happy. I'm pretty proud of myself right now, because I thought you were going to tell me that I was crazy. I wasn't really sure what you were going to say, which would be true if you did. But that seems to make sense to me.
The only thing that I have to say is that at this point, we do not clearly understand the weakness associated with critical illness. So basically, there are some studies now that have been published on JAMA, and unfortunately, I don't think there's not anybody in this country that is really highly interested in this topic, but there are some physicians from the UK and Australia that are really doing a lot of research on that. So what they're doing serial muscle biopsies on these critically ill patients. I remember that one that was published on JAMA in 2013 that they did like day 1, 3, 7, and 10. So basically, they're looking at this muscle cell and understand what's going on, because we do not understand exactly how that is damaged. Like you just said something about neuromuscular blocker, but when you work with transplant populations, when you add the neuromuscular blocker in large dose of steroids, that is even worse. So because that damages the muscle cells, so usually it takes about no less than 12 weeks for those patients to walk again.
You're talking about corticosteroids, like catabolic steroids, as opposed to anabolic steroids. Like
but it's a combination of those drugs. You know, it damages the cells at a certain level that those patients are almost flaccid, and no matter how much physical therapy, no matter what you do, they don't get better. You know, it takes easily 8 to 10 weeks before they're able to stand up and bear weight and start walking. So, but we don't really clearly understand the mechanism that causes that.
Yeah, that's a good. Well, you know, I'm thinking, of course, you know, just again back to the steroid thing, or the testosterone, infusing amino acids and giving them testosterone. You know, you can infuse amino acids into somebody, but if you can't utilize them,
if your cell cannot utilize
testosterone sort of drives that muscle building, you know, engine that gets going. So I would think that somebody acutely ill, even if they're a normal healthy individual, is probably going to have their testosterone level go absolutely to the tank. You know, and so I would think that, at least that's a thought. How much interaction do you do, or have you done, or considered doing with the space industry? Since, of course, weightlessness has a similar phenomenon. It may not be for the same reason, but it has. But the whole point is, you have this weightlessness, so you're not really using your muscles.
Yeah. Well, actually, the best studies are done by NASA. There is no doubt about it. And now they are also using specific exercise equipment for them to exercise in orbit, you know, to save some of that mass. So I do think that there's a lot of incredible information that is being completely underutilized. So right now, unfortunately, a lot of the focus is just how much PT, how many times do you see, how many but we are not really focusing. Like I said, what we need to understand is, first of all, identifying what caused the weakness and what kind of weakness, because it also could be a neuropathy. The nerves could be affected.
Of course.
Because what's happening now, when you talk about critical illness, everybody's talking about heart failure, you know, respiratory failure, kidney failure. Has anybody heard anybody talking about muscle failure? What about nerve failure?
No,
Those things are not, they're at the end of the list, but.
No, this has been extremely, thank you, panel, all solid of it. No, I think that this is, this has been a great talk. And so much out of our consciousness to add this into this. You know, how much of what we've heard today, Patrick, you know, John, in your setting may be a little different, but Patrick with ours, which our ECMO centers are much smaller than John's, but patients who are recovering from their ECMO event, they look like they're actually doing better. Maybe some of this simple, just raise your arms. You know, let's get a physical therapy consult in this patient. I've never even thought about it.
Right.
To be honest with you, I mean, we are very biased. I mean, we get physical therapy consults very, very early. And I mean, I'll tell you, and thanks to, I mean, a friend of mine and Chris's, a German surgeon. You know, Germans are crazy. And he's a friend of mine, so we can say that. And he was with me, just as open, said, Chris, it's your responsibility to get this patient going and extubated and going home. You know something? He had that vision. I'll tell you why. Because about a couple of years ago, I was on a flight to Dubai, and I see this guy behind me, and we kind of know each other. And it was a younger guy that has got a VAD, and Chris had been walking him.
Oh, wow.
You know, and now he's
recognized him.
Yeah, we recognize each other, and he's there at his VAD, and he's traveling all the way to Dubai.
Wow.
So he would not make it that far if he was not walking. I mean, the one thing I want to mention is you always have to be strong for your physical therapist. Do not blame them for anything. If anything goes wrong, it's not their fault. We're doing high-risk maneuvers.
No, we all know.
You have to be supportive.
We all know it's never the physical therapist's fault. It's never the
there's
perfusionist's
something-
fault. It's
there's-
never the respiratory therapist's fault. It's never the surgeon's fault. It's
Always
always the
the
anesthesia's fault.
You're not going to find
We
you
all
outside.
know that. We know
You're going to
that.
find you outside. You know,
Okay.
so I'll tell you, you really have to be supportive of your physical therapy team because things will happen, and you know, we're dealing with a high-risk situation.
Very
And
good.
when we're talking about the walking, ambulating ECMO patients, we're told bad things will happen, and it's part of the deal, and it's okay.
Absolutely. I
But
mean,
that's why
just
it's so
part of
important, the
process.
collaboration, because I am not a physician. You know, I really rely on the physicians to really, you know, assure to me that that patient is safe, you know, to be mobilized away from the bedside, you know, because I can't, as a physical therapist, I cannot make that determination. I really can't. So it is really a true collaboration from everybody in order for this to be a successful, you know, mission.
It takes a village, right?
It does.
It
It
does. There's no question about it. Okay, so how about if we do this? Let's go with last thoughts, since they do final thoughts on the Greg Gutfeld show. We're going to do
Well,
last thoughts. So we're going to start with,
Right.
we're going to go down
Well,
the line. Patrick.
First of all, your presentation was great because I wrote down a bunch of questions and then you answered them before the end of your presentation, so that was great. And then you kind of asked one of mine as well. But what I enjoyed most, it's not really a question, is those exercise beds that you showed. I've never seen anything like that, and that just looks like a great idea.
That
You
is
know,
some
that,
awesome
that was
stuff,
really
isn't it?
cool. Yeah.
No, I learned something
So-
from this today. Let me
Yeah.
tell you what, from everybody. I learned from everybody today.
Yeah.
That's what makes these programs so great, is that we learn something. That's the whole point.
So, you know, can you see our patients exercising like that? I can't-
Like that?
Yeah, because, and John, you kind of asked the question.
Well,
It was,
I mean, if
how
you don't,
soon? Go ahead.
if you don't have an active physical therapy coming almost the first thing you want to do, get the patient to wake up and sit them up. The first thing they need to get off the anesthesia drugs, wake up and sit up. When they can sit up, they can start. That right away is going to help improve your success. Then when they can stand up and walk, no matter how they're cannulated, make sure they're secure, make sure you do it safe. But the physical therapy part will improve your ECMO outcomes tremendously. If you
Oh,
don't
I
have
totally agree, because
if
I think-
you don't have that going on here at Houston, I'm sure.
No, well, sure we do where they are. We don't where we
Well,
are.
you're missing
And
a
I
big
think-
element.
Yeah, we don't.
Big
I
element.
think we are. I absolutely agree. I think that it just helps with the patient's mentality. You know, I mean, we all know it. I mean, what would a surgeon do? What would any heart surgeon, any good heart surgeon do if the patient the morning of surgery says, "I ain't gonna make it"?
Cancel.
Cancel the case.
Absolutely.
Okay?
You have,
And when
to,
you
you have to
can
cancel.
get
Like,
patients who are that sick and start them moving, they start to have a purpose, and that purpose becomes, you know, a positive thing, and that positive thoughts make a huge difference. Patrick, I didn't mean to interrupt you.
No, I think we've covered
just-
it. I
I
mean,
just go on and on
like
sometimes.
day 3, can you start thinking about? That's when you can actually start thinking about waking somebody up and getting them to even sit up. We
I
just
don't
don't
think
wake
that
our
there's a
patients
day.
up. That's the thing.
I don't think there's a day.
Yeah.
You try to wake them up as soon as possible,
Yes,
and if
but-
they're non-combative, and they can respond, you're on the right path. If they're combative, then you give them another day or so. You don't just put a number on it, right? And you try to get them awake
I think
and
what
going
you-
as soon as possible.
But again, we have to be careful with the combative part and being a physical
Right.
therapist, like, because a lot
Right.
of times if you have somebody who can't breathe, and before
Right.
they were sitting up because they couldn't breathe, and now they're awake and they are lying down, that is going to put anybody in panic if they're intubated and all that.
right.
So a lot of times we do not quite understand the reason why they are, they could be delirious, there could be a lot of reasons, you know.
They
But
could not be
someti-
hypoxic.
Yes, there's
You know,
different
and
reasons.
creating all kinds
But
of
as a
issues.
physical therapist, I have found throughout my career, I mean, I would not be able to count how many patients that have chronic back pain and they're stuck in a position in the bed that they're in so much pain that they're
Yeah.
just, or they can't breathe. So a lot of times, and it's hard to understand why, because they cannot talk to you, and then a lot of times they're not fully awake. But that can be a problem. Sometimes I see that it's delayed because of that.
Yes, absolutely. And I think that's you know, Patrick, to answer your question, I think when we get a patient that we put on ECMO, and you didn't even actually talk about this, Dr. Samir. I didn't see, at least I didn't hear you say anything about it. You may have had it in your slides. But you have a patient who's been in the ICU for 7, 8 days, They've been on maximum ventilatory support for the past 7 days with peak pressures 35, 40, maybe even 45, sometimes even 50. They've been on 18 and 20 of PEEP for the past 7 days, 100% FiO2 for the past 7 days. That patient's probably, and they put them on ECMO. Patient's probably not going to recover.
There's no
And that is a
question.
big
No.
problem. And so I think that when we see patients who have at day 3 and 4 of that scenario, they may have a chance of surviving, but had they put the patient on ECMO at day 1 and gone, or day 2 at the latest, and gone to maximum lung rest vent settings and protected those lungs, then at day 3 or 4 of ECMO, they may be awake. If they can move and not desaturate and decompensate rapidly, well, then you can start, just by being awake, we've seen that, then you slowly start moving things to see what is their reserve. And I think that the more you can do that, the more likely they're going to mobilize fluid, their lymph system is going to start actually working, because it doesn't work worth a darn when you're paralyzed, you know that. You know, so you have you get all that third spacing cleared, the lungs dry up faster, they start moving more, and you can get those patients decannulated and off ECMO a lot sooner and safer, with a better opportunity for long-term survival, not just short-term survival. Getting them weaned off ECMO is only half the battle.
Oh, yes.
They got to walk out of the hospital. If they don't do that, then it's not a success. You know, wean them off ECMO all day long. They died in the hospital. What good was it? Or at the rehab center or whatever, and they just never made it out. I don't think I see the value in that. You know, I don't think it's fair. Final thoughts, John?
Well, I was saying about the getting the rehab going and the value that it is for an ECMO program. Wake them up, sit them up, and just like she said in the talk, the best position for the lungs is upright. Everything starts to improve just about
Clearly.
almost right away.
The VA
so
ECMO
even
works
if you
so
can't
much
get
better
it,
when you sit somebody up at least 30 degrees, and I prefer 45 degrees.
I mean, if you can't get them out of the bed, get
the diaphragm
put
off the lungs.
and recline the bed and raise the bed. So when you were talking about when indications to stop walking, you said if the SaO2 drops below 75%.
SpO2.
Yes, PO2. How are you monitoring that? Like, should she know how you're monitoring that?
I don't know.
So
Are-
you-
are
The
you-
O2 sat?
Pulse ox.
Well,
Okay,
yeah,
but
but
the
see,
S-
that's my point. If
but
it's
the
a pulse ox,
SpO2
but the
is-
pulse ox, we usually don't. The patient's not pulsatile enough a lot of times, and we
yeah.
don't get a good pulse ox.
Yeah.
So that's why I was wondering.
They
if-
might have
because-
one of those continuous meters of some sort, you know, that draws the blood.
No,
like
we
the
don't
old-
use that. We just
No,
use
you
the
just run
routine.
the-
Yes,
run the
and
blood
also we
gas.
monitor the patient very closely.
Yeah,
And,
well, we see this too.
Yeah,
the pulse ox.
when the lips turn
They
blue,
may not.
Yeah.
the SpO2 is low.
We're watching the pulse ox, which is like you're really focused on that. Next thing you know, it's just not working.
Right. 'cause you
No,
have-
no. I
Yeah,
would say
so we
no.
see
We
that a
are
lot.
checking to make sure that it's matching and all that. I think that is just for safety.
We just go without it if it's not working
I
until
think
the
that-
patient don't
Yeah,
walk.
you're right.
Maybe
Uh-huh.
not. Well, yeah, I think you can just infer, you know,
Yeah.
that if this patient is decompensating from oxygenation, you know, if the SpO2
And you
is
start
under
watching
75,
you can watch
they're
your
not gonna do well.
SVO2s pretty quick after that too and see
Yeah.
they'll change as well.
Yeah. Dr. Samir, final thoughts? Or
I think right now is you really have to. ECMO is a very important resource. Use it judiciously, and don't be emotional. Every patient you think about ECMO, I will get a palliative care consult if you have the time. If not, you have to look at the whole situation. See this patient is what's just going to walk out the hospital, have a meaningful life. It's not just live; it's having a meaningful life. And a meaningful life is a very important definition.
let me ask you a question. I got a question for you. You have a patient, they're decompensating, the surgeon or intensivist or cardiologist or somebody, it's a life-saving maneuver. They just put them on ECMO. They don't even get consent from the family. Put them on ECMO because that's what you got to do. Or you go, let's say you see the family and say, we put him on ECMO where he dies right now, and they put him on ECMO. Why is it that now that you put them on ECMO and they're bleeding out or whatever other problem occurred. They have a belly infarct and their lactates are climbing up, and it's just they're obviously not doing well and not going to make it. Why is it that you have to wait until the family now says it's okay to discontinue the care if you really didn't even involve the family or barely involve them with actually initiating the care? Where does this come from, and why does this happen?
To be honest with you, I mean, it's a good question, but I think palliative care helps with that situation. Palliative care is not just, it helps talk to the family and helps, will give them the realistic. Palliative care is a neutral, entity. There's giving a real evaluation what's going on and help the patient, family arrive to the decision that's the best thing for the patient.
Well, what do you do when the family says, absolutely not, keep going, 100%, we don't want to turn anything off? But it is futile care.
At this point, you have to get ethics consults. And medical legally, you do have to get an ethics involved before you proceed anything else. You have to get ethics involved. And to be honest with you, again, we established that for every transplant or MCS patient, to get ethics and palliative care consult. To be evaluated, they get both consults. It has worked very well. Patients thank us, and the families thank us. There's no family ever was angry that you give them the realistic picture of what's happening and what the future is.
That's very important. I agree.
Yes,
with
and
you.
I think everybody appreciates the honesty and transparency. If you're honest and transparent, nobody ever gets mad at you. Okay, people who think they're being evasive or hiding, be honest and transparent, And you have to make a plan before this happens. Like if you saw somebody who's very high risk, and we have one of our surgeons say, well, this patient comes crashing to a double doors, what we're gonna do? Nothing. We all agree. Palliative care. We're going to be comfort care, and that's what everybody says. That so before it happens, and you're doing a journal club at the end of the night, because those journal clubs do not work out. Emotions take over at that point.
Understood.
Yeah.
Chris?
Like I said, it's just not because we can do it. We can walk patients on ECMO that we should. So I think that is only for selected patients. And I also just want to make sure that everybody understands that there's this idea that if the patients are going to walk, that they're going to do better. I can agree to a certain extent, but we also have to understand that the ones who can walk, they're probably not as sick as the ones who cannot walk. So the fact alone that they're walking just means that they have a little bit more reserve. And also, do not underestimate that what you can do at the bedside. I've had patients that I did not feel comfortable walking away from the bedside. However, they were taking literally 1,000 steps at the bedside. They were walking one step, so they were doing a tremendous amount of walking right at the bedside, where I felt like for patient safety, if there was a change, all I have to do is just to let the patient down into the bed, and we can provide whatever care they need, versus that you are in the middle of the hallway, like 500 feet away from the bed. As a physical therapist, that is always in my mind. How can I safely bring that person back to the ICU bed? Because I definitely don't want this to be too late.
Or the helicopter pad.
Exactly, whatever. So again, don't think that just the walking, that is, because...
Would you agree any exercise, anything is better than nothing?
Oh, absolutely. There's no doubt about it.
Anything's better than nothing.
Yes, absolutely. And the sooner the better.
Very
Prevention is a lot better than treatment, because we don't have a whole lot of treatment for that.
Very good point.